Ken?
Okay.
Yep.
Okay.
All right, we're live.
Okay, good afternoon. And thank you all for joining us for today's program, African Americans, the Death Gap, and Health Equity, One Doctor's Perspective. This event is sponsored by 3 Tompkins County departments: Human Rights, Health Department, and the Chief Equity and Diversity Officer, and the Ithaca College School of Health Science and Human Performance, and the IC Department of Health Promotion and Physical Education. I am Ken Clark, Director of the Tompkins County Office of Human Rights. We are joined today by Dr. David Ansell, Senior Vice President for Health Equity and Associate Provost for Community Affairs at Rush University Medical Center, and by Dr. Kristen Pollock, one of Dr. Ansell's associates at Rush Medical Center. I'm glad to have both of you with us today. Dr. Ansell is the author of the important book, The Death Gap: How Inequality Kills. The publisher of The Death Gap, the University of Chicago Press, describes how Dr. Ansell addresses an overlooked aspect of the accelerating gap between rich and poor in America: their health. The poor die sooner, according to the University of Chicago Press. Blacks die sooner, and urban poor Blacks die sooner than almost all other Americans. This disparity constitutes the death gap. In his introduction to the book, Dr. Ansell powerfully sketches the geography of the death gap and in his analysis of one major Chicago street, Ogden Avenue. Ogden Avenue was once an important Midwest link to the legendary US Route 66, the subject of a popular song by Nat King Cole in an early 1960s TV series. I'm old enough to remember both of those. Ogden Avenue, Dr. Ansell wrote, connected wide lawn western suburbs of the Windy City to the edge of steel and glass towered Gold Coast and to some of the lowest income, most economically distressed communities in the country. A 20-minute drive on Ogden Avenue reveals, and I quote, a nearly 20-year life expectancy gap, unquote, in the neighborhood sandwiched between the western suburbs and the Gold Coast. The life expectancy gap has been intensified by what our speaker has termed structural violence, the white flight of the 1950s from urban neighborhoods to escape growing numbers of African-American residents, the migrants of the Great Migration, goaded by racist fear-mongering by real estate agents and corrupt government officials. Deindustrialization, what sociologist Julius Wilson called the disappearance of work, which also led to the disappearance of wealth and health benefits. The resulting increase in poverty and deteriorating neighborhoods. Add to these factors exploitative housing policies, the redistribution of wealth away from the laboring, working, and middle classes over the last 4 decades, often masquerading as tax cuts primarily benefiting the rich and corporations, and racist policing and incarceration, which has ballooned the prison population 3-fold since 1980. These structural factors have led many health professionals to conclude that racism is a public health crisis. Our guests will speak in further detail about the gap and the death gap and the actions needed to repair this breach. We welcome you, Dr. Ansell, and we also welcome you as well, Dr. Pollock.
Well, thank you for having us. And this is a really important subject. I'm not going to have slides. Dr. Pollock helped co-author The Death Gap with me. And, this was a book that was started, in 2012. So it's very fresh in our eyes right now. These are long-standing problems. And I wanted to maybe start with a little bit about myself and my background and sort of my evolution as a doctor. And I want to frame it around a question. What if everything that we think to be true about health and healthcare in America is wrong. I'm just going to frame because in a little bit of my story and how I got to where I am now and what I'm going to tell you. And in the context of this, I will just say the words we use are critically important. And I will highlight this as we go forward. And we'll take over there and ask Kristen to jump in too as we sort of have this dialogue, because she's been engaged with this work as well since she was a pre-med student. She is now a resident. While she's a Rush colleague, she's at up in Milwaukee doing her internal medicine residency, but a colleague in this work. So I'm a son of immigrants and from Europe, and my parents came here after World War II. They were the few survivors of their families who were wiped out in the Holocaust. And I point this out not for sympathy or even empathy on that, but just to say that that's a fact. My mother, who died a couple years ago, we got a picture in the mail, actually email, no one mails anymore. And it was from the files of a Nazi soldier. And it was her grandfather's picture posed in front of tombstones with a yellow star on his arm. This was 1941. In 1939, my grandfather and uncle went to Poland to ask him to come get out. They were in England. And he said, no, I have to tend my flock. We know he was murdered the next year by a Nazi. And my mother's cousin, trying to protect him, was murdered as well. It didn't matter. They all got murdered. The form of murder was less important. But, as a young child growing up post-war in the United States in the early 60s, I was very aware of this European history in my family. Victims of racism, white supremacism, actually. The white supremacism of the Nazis was, they came to the United States to study this because it was perfected in the United States, and the Nazis just took it to another level. White supremacism, mass incarceration, and genocide. So when I grew up in this country, you couldn't help but see the civil rights movement and seeing the parallels between that. And as a young man, that led me to become a doctor because I wanted to do good. But as immediately I got into medical school and observed how the whole system was wrong. I couldn't articulate it very well in the first year of medical school, but ultimately came to identify the problem. And it wasn't just about being a doctor. And I found my true north at those times. And it wasn't just to be a doctor. I'm an epidemiologist, I'm an administrator. But for me, a human rights activist, because this is a country in which health is not a human right. Healthcare is not a human right. And as you're going to hear, we have a racialized system of delivery that's based on really what makes the most money and who makes the most money. And because insurance cards, like everything else in this country, layer out with white on top and brown and black on the bottom and the rich on top and the poor on the bottom, we ended up with healthcare delivery systems racialized. And we saw the abject failure of this with COVID. And we'll come back to this. Just to say, the United States has had more deaths than any country, more deaths per capita than any country, and the wealthiest nation in the world. An abject national failure with disproportionate Black and brown deaths, but deaths across every community. And a lot of my thinking evolves from the fact that if we take care of those who've been most marginalized, we take care of everybody. So that's a little bit of that background. That background brought me to Chicago to train at Chicago's Cook County Hospital, public hospital, which was at the intersection of everything that was right and wrong about health and healthcare in America. A hospital that took anyone, regardless of ability to pay, but the quality of the care that you could deliver was limited many times by what the assets were. It wasn't the doctors, it wasn't the nurses, certainly wasn't the patients, but it was what we had available to us. And literally across the street from where I work now, Rush University Medical Center, a bright, shining tower to great medical care. I spent 17 years at Cook County Hospital and another decade at Mount Sinai Hospital, literally down the street on Ogden Avenue, which was originally a Native American trail. So while it was Route 66, before that it was the Potawatomi Trail. So we always have to remember history because we tend to bury history and the names and the memory of the people who were actually there. So Chicago's where it is because it was always a great transit zone, and Native Americans had discovered it many years. And I worked literally across this old, now 42 years, right along the old Potawatomi Trail. Of course, no one knows it anymore. But it was that experience that I did call one street, two worlds when I got to Rush. So I was, I rose the ranks of academic medicine. I was the division chief at Cook County Hospital. I was the chair of medicine at Mount Sinai, residency program specialist. I was, the inaugural chief medical officer at Rush. And yet I couldn't help but think, because my patients and I came to these, followed me, and we did a litmus test on the health system. I got to Rush in really the pinnacle position of clinical medicine at academic medical center, where our whole focus was on quality and care. And I can tell you, we ranked one and have ranked one or in the top 10 of quality among the nation's health systems for almost all the years I've been here at Rush, and we're a U.S. News and World Report honor roll hospital. But when I got to Rush, I couldn't help think that something was terribly wrong, and I couldn't figure out what it was. It was a little bit like if you've ever been to a concert and you leave and your ears are ringing afterwards. There's that sort of something's going on, and the memory of that concert lingers. And so while I was doing the chief medical officer job, I wrote 2 books. One, a memoir of my time at Cook County called County Life, Death, and Politics at Chicago's Public Hospital, and the one that Kristen wrote with me, The Death Gap. Literally met her on an elevator. She was pushing my mother out of the hospital. I needed someone to help me think about this. Now she's a doctor in her own right doing this work. And together we went on this exploration of what's wrong. And so that's why I like having her with me on this. And so we began to do this research and found this statistic that we talk about in the book, The Death Gap. By the way, The Death Gap's being re-released by University of Chicago Press. Mayor Lori Lightfoot has a new introduction to it. And I'll tell you about that in a little bit. And I have a new afterwards that reflects on COVID. So we began to do this exploration. I remember sitting with Kristen and saying, we know people die earlier, but what's the biological mechanism for this? And I'm going to, in a second, have her talk about that exploration, because I think people need to understand it. So what happened to me is when I went from Cook County to Mount Sinai, Sinai is located in the Lawndale community of Chicago. It was a community that in 1950 had 120,000 white people living in it, mostly Jews, Eastern European Jews who came in the late 1800s to the 1920s. A very vibrant, rich Jewish community. Mount Sinai, of course, a Jewish hospital. By 1960, 120,000 white people had left and 120,000 Black people had moved in. Now you've heard about redlining, you've heard about all of the things and all of the things that underpin it. I look out of my window of my office at 2 towers I could see from the corner of Ogden Avenue, the Potawatomi Trail, Sears Tower and Western Electric Tower, both of them now out of the community. So it wasn't just that white people fled, businesses fled. And I'm sitting there trying to understand what does that have to do with the patients I'm seeing? And that led, I mean, those questions as a doctor, and I began to have the sinking feeling that of the question that what if everything I learned in medical school was wrong? And it was when I got to Rush and realized the riches of a place like Rush compared to where I was, same doctors, same patients, different opportunities. And the idea that across the street was Cook County Hospital. And I began a thought experiment. Imagine the Martians came to Earth and landed right by Ogden Avenue. And they landed a little bit further to the east, and they landed in Rush, and describe back to Mars what this place looks like. Well, very nice, very fancy, a lot of white people here. The Earthlings seem to be, it's got a lot of things. But had Martians landed literally across the street, well, the Earthlings are all black and brown. It's a little run down. It seems a little bit chaotic. And yet people go by their normal days normalizing this. So as we explored the death gap, we came up with this stat that's in there, which a 16-year-old teenager who grows up on the west side of Chicago has a little bit more than a 50-50 chance of living to the age of 65. Think about that. It's called premature mortality, early mortality. And, Kristen and I would go and give these talks, and that we always put that fact in there. And that's from an article in the American Journal of Public Health in 2011. And we ask why. What's the cause of death? Hands would shoot up in the audience, and people had the answers right at the tip of their tongue. And we would show a picture of this young teenager, with headphones around his neck, smiling there, and they would say violence. Because the image of a young black man in our unconscious bias heads always, 100% of the time, triggers violence and fear. And I then revealed the facts. It's form of violence, but it's structural violence because it's, and back to what you said, Ken, because it's designed and structural, because it's designed into the way our society, towns, neighborhoods work. It's designed into our laws, our policies, our procedures, our norms, and our values. And it's violent because people are harmed as a result. So when you look at the number one cause of death in these neighborhoods is cardiometabolic disease, chronic diseases. Number two is cancer. You get into then infectious disease, HIV/AIDS. Yes, then there's homicide, infant mortality, and opioid overdoses. You can actually come down to 5 diseases that account for about 70% of premature mortality, not just in Chicago, all around the country. Made me begin to think about root causes, but I want to pause and ask Christian to maybe talk about the work that you did around how does neighborhood conditions, the conditions under which people live, work, and play, or decisions about how money, power, and resources are decided, how does it cause biological illness? Do you mind speaking about this for a sec?
So what we found during that time, we tried to dispel this idea that whenever we would take a look at something, for instance, like breast cancer, they would say would occur in African-American women differently, they thought, than in white women. And they found that over the years, the breast cancer mortality rate between these women was different, that Black women were dying at a much higher rate than white women. And they tried to attribute this to a purely biological difference, that they said there was genetics, that Black women got more aggressive cancers, etc. But the thing that we found when we were looking further into it is that that wasn't necessarily the entire cause. And it couldn't even necessarily be attributed to being any cause that was 100% proven, but that there was differences between different cities in the mortality rates, similar population makeup, similar amounts of disparity, but differences in the mortality rates. And that shouldn't be occurring if it is purely genetic. If you look at someone who is from Africa, if you look at someone who is from New York or Memphis or Chicago, if it's purely genetic, you shouldn't see these different mortality rates. And so over time, prior to my coming on board, they had created a task force in Chicago that was initially called the Chicago Metropolitan, the Breast Cancer Task Force. Now it's called Equal Hope because they've also taken on cervical cancer screening. But the idea of this task force was to investigate and determine why these mortality rates were different. And when David and I were writing the book, we put together this idea that there was the 3 B's: beliefs, behaviors, and biology. And that these 3 B's were what people were attributing to Black women dying earlier. They said that, oh, you know, they don't take care of themselves as well, perhaps, you know, they don't go see the doctor, that's behavioral. Biology, they have, you know, a different type of cancer that they're having genetically. And we found that that's just not the case. You should see this repeated in different cities. And instead we use the example of the task force where they went in, they used very quality metrics, higher level data to look at benchmarks at different institutions around the city of Chicago. And what they found was that in the poor neighborhoods, the ones that are largely Black and brown due to segregation and the history of redlining, those particular neighborhoods tend to have hospitals and medical centers that are not necessarily accredited by the different cancer foundations, that they employ general radiologists, perhaps instead of mammographers, to read their mammograms. And why? It comes from a cost perspective, because these centers are not reimbursed the same way as centers in affluent areas are. And so they in turn service their patients differently. And these patients were falling through the cracks. And so if you went in through the task force and provided different training, different quality metrics and benchmarks that needed to be met, the theory being we should be able to improve mortality in those cases. And they found that over a period of 10 years, the mortality gap in Chicago between Black and white women with breast cancer actually changed. So that gap where white women were up here and the survival rate of Black women was down here, that gap actually shrunk over a period of 10 years. And so if it was truly these other 3 B's and genetics, that should not be the case. And so we make the argument that this is not just seen in breast cancer, this is seen in all types of health conditions. Your neighborhood affects asthma. For instance, we looked at children and asthma. If you grew up in the projects and you were subjected to being in a different area of the city that has more pollution in the air particularly, your asthma rates are going to be higher. This is also played out across the country in other areas such as Seattle. They had done lots of studies out in Seattle and took a look at that. We find that with all types of adjuvant chemotherapy, any sort of cancer or any sort of biological condition that can have therapy associated with it, with like adjuvant chemotherapy, et cetera, and other services, if you do not have the same access to those services, colorectal screening, for instance, you're not going to have the same mortality rates. You have to have equal access and equal opportunity to have those outcomes. And so that's what we found in this chapter, essentially.
And it's, so maybe Kristen, you could put in the chat the article that you wrote with me. She's the lead author on structural racism, a case of a 60-year-old with breast cancer in Chicago, which is a very short summary of this work. So I think that so part of the discovery was, you know, what we were taught in medical school may have been wrong. So I wanted now to present you with what happened to me. So we were writing this book, and it takes a long time to write a book, especially if you're a bad writer like me. Kristen's a terrific editor. She's always critiquing me. She's half the time wrong. But, you know, eventually we got the book out. But at the same time, I was asked to do our community health needs assessment at Rush. The Affordable Care Act under Obama had a lot of regulations that open up insurance more and other things. And but one of the things was a requirement for not-for-profit hospitals to do a community health needs assessment. And the first one was 2013. I think our business office did it, but so it was kind of a meaningless task. But in 2016, I took it over. And I'm an epidemiologist, meaning I look at rates of disease in one neighborhood compared to another neighborhood along the lines of what Christian said with breast cancer, and just a visual for breast cancer in Chicago. So there are accredited hospitals. You can get accredited for quality for breast cancer work. And if you look at the map of Chicago, the neighborhoods with the highest breast cancer mortality were Black neighborhoods on the south side and the west side of the city. And yet all the accredited hospitals were on the north side of the city. And you had to ask yourself, what is with it with these women that they're going into neighborhoods where the hospitals aren't accredited, right? But it's of course not that at all. The neighborhoods where the hospitals were accredited were largely white neighborhoods. Or when you looked at the difference in breast cancer between New York and Chicago, people in Chicago, when we began to present this gap, said, well, it's biological. We're seeing worse breast cancers in Black women. So when we saw the difference rates in New York City, we asked what happens to Black women's genes when they cross the Allegheny Mountains. This idea that it was structural was beyond people's understanding. So when I took over the community health needs assessment at Rush, we presented this map, which I'm going to talk to you about in a visual. And then I'm going to talk to you about the language that I acquired as an old white man. So we did this map in our community health. We're located on the west side of Chicago, about 2 miles from the Loop, in what's called the Illinois Medical District. And like I said, when I was chief medical officer, the goal of the hospital was to be among the best in quality, and we were ranked #1 in the country. And a U.S. News and World Report hospital. Like you couldn't get a better, maybe as equally good hospital, but not a better hospital in terms of clinical care. And that was my job. But I did this community health needs assessment, and I'm going to give you that visual. If you lived in the Loop, which is 2 miles to the east of us, you can live to be 85. In fact, in some districts, some little neighborhoods, over 90. But if you go down the blue line of the Chicago Transit Authority, 7 stops, 3 stops past Rush, life expectancy plummets to under 69. And that's where we did this visual of the 16-year-old child in that neighborhood. And that when you ask yourself, when was the last time in the United States that life expectancy was under 69? Actually, in some little districts, it's under 65. So up to a 30-year life expectancy gap, literally 3 stops from our hospital. And we presented this, there's more to it, but we presented this to our board. And it was at the time our mission changed from being the best in healthcare to improving the health of the individuals and diverse communities we serve. And that was probably the first time in our mission statement we said improving the health of communities. And that's kind of when I had my aha moment about everything being wrong about medicine. Now, it's not the first time in history this has happened, that we've got it all wrong. So from the time of the Romans to the late 1800s, people felt that ill humors caused disease, odors. And your human rights department, there may be some health people here, but there was a pandemic a worldwide pandemic in the mid 1800s, is cholera. And cholera was spread through British trading, like this pandemic was a travel related one. And it went to London, and there was an anesthesiologist, a new field. Actually, he performed anesthesia on Queen Victoria's C-section. So he knew that breathing in your lungs couldn't be causing disease. And he mapped all the deaths that were occurring in a certain area of London. And it was around the pump on called the Broad Street pump. and he convinced the city officials to take the handle off, even though his ideas that it must be something in the water were wrong. And it wasn't until the late 1800s, so this was 1854 or something, 1850s. It wasn't until the late 1870s that a French chemist, Louis Pasteur, discovered that bacteria caused disease. So from the time of the Romans to the 1800s, we had it all wrong. And now we're in the era of the biological basis of disease. Germs cause disease, our genes cause disease, our behaviors cause disease, you know. But I look at that L-track, and I look at that 30, 25-year life expectancy. And as a doctor, I start to think about things. So I say, well, gosh, if everyone in Chicago who needed it got a pill to lower their cholesterol, remember, heart disease is the #1 cause of premature mortality. If everyone who needed it got one, how much would we add to life expectancy? 20 minutes. But what if I, as a doctor, could work on the underlying structural conditions in these neighborhoods, which I'm going to talk about in a second? What if I put my energy into those conditions that produce, listen to my words, produce poor health? Where's the greatest benefit? And I quit being chief medical officer. I mean, it didn't happen just like this, but there was this is what happened. And I moved into a role about being a chief health equity officer at Rush to really lead a new strategy that our board decided on. Think about, we're highest in quality, but our board said it's not enough. And we were one of the first places in the country to make equity a strategy. A lot's gone into this. I'm going to tell you a little bit about this and then be able to take questions as well here. But I want to tell you my personal journey. So here I'm a doctor. My parents came from Europe. My family was wiped out in the Holocaust. I had my own family experience with white supremacism and genocide. Painful. I can't even look at pictures and stuff. It's visceral. And when people ask questions, well, why? Well, slavery was like all these years ago. Why is it still felt today? I know what that feels like. But in this country, I was assigned to whiteness. And I was assigned to privilege. And while I'm a smart guy and I've done a lot of things, much of it is unearned because of my assignment. And when I was about 60, I began to speak publicly about racism. It wasn't I didn't know about it, but I never said it. And one of the things we do in medicine, if something goes wrong, is we do something called a root cause analysis. So if someone comes in the hospital or a clinic and they're meant to get something, let's say they get the wrong medication and they get sick, you got to do a root cause analysis where you go down, and it's oftentimes more than one root cause, but you need to put it together so that same thing doesn't happen again. So I did a root cause analysis on myself, and I said to myself, why? I saw a video of myself, and it's when we started doing this work on breast cancer, and I was talking about discrimination and segregation. And I realized, why did I say that? And why didn't I say racism and white supremacism? I just asked myself. And I did a root cause analysis of myself. If you ask the question why 5 times, you can get to the bottom of almost anything. So why didn't I say it? Well, I didn't feel that comfortable. I wasn't facile with the words. Well, why wasn't I comfortable? Because I'd worked in these settings. Most of my patients are Black and brown. Why didn't I feel comfortable with the word? Well, people didn't talk about this in polite circles. Well, what were the polite circles they didn't talk about? Well, kind of the circles I was in. Well, what are the circles I'm in? Well, I'm in senior leadership at Mount Sinai, at Cook County, and Rush. Well, who's in those circles? White people. And I realized that I was, that it wasn't just my talent that got me in the door. It was my familiarity, I call it my that my skin color and my Y chromosome, that made me familiar. And I didn't speak up about racism and white supremacism because no one talked about these things. And why would I want to talk? I can tell you my Black colleagues never would. They're usually the only one in the room. There's zero value. You don't get to where you are as a Black or a brown person by speaking of these things. And I thought about the Me Too movement in recent years. It wasn't up for women to speak on their own behalf, it's for men. Or I thought about the Poland. It wasn't up for the Jews to speak on their own behalf. It was up for the good people of Poland and Germany. So as a white man, I began to speak publicly about racism, because you have to name the root cause. You have to understand what's the problem before you fix it. And in our community health needs assessment in 2016, you can look at it online, Rush, we named structural racism and economic deprivation. Those were the words I used. I didn't want to use poverty. I wanted to make it say these are acts of affliction, acts of oppression. They are human-made, oftentimes man-made, not excluding women from this, but they're human-made. They're acts of affliction. They cause harm. They cause premature mortality. People are dying as a result. And never in my career did I say it. In our report, I kept saying it. The writers kept writing it out. And for a long time, I said, I'm going to say these words to you on a TV show or something. Do not erase them, because people were erasing the words as if it were a gentleman's agreement not to speak about it. And so I really urge everyone who's out there, who's white, who's a leader, or white who's not a leader, to get comfortable naming it. It's not the only form of exclusion there is in the world, and it's not the only form of gradation. But you could begin to sort of, when you start to name it as a white person, you begin to look at the room you're in, the decision ever be made, and asking the question, how does the decision we made, or how does this room that's been assembled reproduce historic injustices that have white on top and brown and Black on the bottom, men on top, women on the bottom, able-bodied on top, go on and go up. So the point is that we're going to get better when we begin to systematically apply an equity framework to our work. So just a couple other observations about this. I'm going to talk to you about COVID for a second, and then we'll go to questions and answers on this. So the words matter. So I called it economic deprivation. I just saw a speech by Martin Luther King, who was in Chicago, 1966. He uses the words economic deprivation because they're acts. Poverty is like, it just happened. Even segregation was like, oh, it just happened. No, they're acts of oppression. And if you look at what's happened to capital in these neighborhoods, the capital was removed back to the Sears Tower. White people fled. Why would a white business person who thinks Black neighborhoods are bad neighborhoods put their business there? So they moved. An act of violence. Now you can imagine when I first started saying this, people were shocked. But as time went on, we began to, so as an organization, we said we have an obligation to the social and structural conditions under which people live. We're a big business. Let's leverage our business operations to buy locally, to support local businesses, to hire locally and create career pathways to wealth, to invest locally from our investment portfolios, to help build the infrastructures for these communities. And then we got other hospitals in Chicago to join us, and we partnered with the community in a racial health equity collaborative. I'm named very specifically because racism was a root cause. We got everybody to agree in a big aim to reduce that life expectancy gap I discussed to you by 50% by 2050. And just to bring home the ideas here, we say it's not just people in the neighborhoods, it's people who work at our own institution. We lined up our own employees along the L track, and in that lowest life expectancy community, 1 out of 5 of our employees was experiencing severe financial distress. What's that like to come into work every day? That's Hank, the transporter, This is this one. And they would come into Rush, they'd work for 30 years and they retire poor. It was never our intention. So how do we lever this? And we started doing that in Chicago. And we call it West Side United. You can look it up. But then COVID hit. And to a big surprise to many, but not to any of us, COVID planted its roots into the pre-existing crevices and chasms of our society. So the underlying pandemic is one of white supremacism. And we all swim in that sea of white supremacism. And it's created historical disproportional life and death rates. We can talk about maybe racial capitalism, the way that our healthcare system, we don't have health as a human right. We have a capitalist healthcare system that also gradates from white down to brown and black. So the services in black and brown communities are different. There's a whole set of root causes that when COVID hit, there were disproportionate death rates. In the first 100 deaths in Chicago, 72 of them were Black people. The mayor, Lori Lightfoot, who read the death gap when she was running for mayor, but she's an attorney, she read it but didn't viscerally understand it, said when she saw the statistic, it takes my breath away. No one should think this is acceptable. This is actually, she writes this in the foreword of the death gap in its re-release. She asked her staff, what should we do? And they came up with ideas. And she said, call West Side United. Now imagine what it took to get 6 hospitals to agree to share power with the community, to agree that our aim is to reduce a life expectancy gap by 50%. No one wanted to sign on to that. They said, oh, we can't say that. But the community said, are you kidding me? But now COVID has hit. And she calls us up. She said, that's not good enough to her staff. Call West Side United. On a Sunday night, I get a phone call. It's the mayor's office. And we get on the phone with our leaders from West Side United, 2 Black leaders, and say, how should we approach it? We said, we've got to be data driven. We've got to follow the data into the communities. 2, we've got to set a table that had the providers, including the community health providers with the hospitals, the city, and the community anchor organizations, community-based organizations. We can't just look at this as an ICU problem. It's a problem of how resources in the community. And then we systematically got to take steps week by week to attack this in the neighborhoods. And it's called the Racial Equity Rapid Response Team. We did a lot of work and have done a lot of work in that. And I think Chicago, you heard about New York running out of beds and ventilators. You've heard about LA, you've heard about Houston, you heard about Phoenix. You haven't heard about Chicago because we've taken a racial equity approach. I'm not saying we've gotten it all right, but the idea is the resources need to be in the community and not just health resources. And we need to follow the community. So I'm going to end on just a couple of principles, and maybe in the question and answers phase, maybe Kristen can talk about racial capitalism, because I think it's really a critical thought here. So number 1, principles of this work. We've got to speak honestly to the root causes. No one can look at this country and the response to COVID and not say something is seriously wrong, and we've got it wrong. And it's up to us to rectify. By the way, it's in our hands to do this. It's not just Chicago, it's the United States. 2 is nothing about us without us, that the community has to lead these efforts and we have to follow the voice of the community. Number 3 is don't underestimate white supremacism as a system of oppression that will frankly kill all of us until we take personal accountability. And white people, I'm talking to you, and we take personal accountability. My family was wiped out, 6 million Jews and many more millions other people, because of the tolerating this to get out of hand. And what we saw in the Capitol, what we've seen in this country, what we've seen for hundreds of years is that toxin. It's deadly, and it puts us all at risk. And so those are the points I want to make in this work. And I have to say, I never thought I quit being a chief medical officer to full time for this work. There could be nothing more urgent, more important than this work, but it's got to be national in scope. And I'm going to end there and maybe take questions, Mr. Clark.
Okay. All right. Let's see.
Could we just maybe have Kristen talk a little bit about this idea of racial capitalism? Because I think it's important for the audience to understand this. Kristen, if you feel comfortable giving it a shot.
Okay, and then we'll follow up with the first of our questions.
Sounds good.
Well, I can go and I could give it a quick shot right now. I would say the one thing that we talk about, we were writing another paper that deals with racial capitalism, is the fact that our US healthcare system operates within capitalism. We do not have, like some other westernized countries, a national health service. We do not have single payer healthcare for everyone. We function based on a capitalist market. And the fact of the matter is healthcare cannot function that way and be equivalent for all, because people receive healthcare in different locations. People have different access. People have different environmental issues that are the root causes, but inevitably it boils down to the fact that you cannot have privatized healthcare delivering equal healthcare to everyone the same way. And we call it racialized capitalism because what this boils down to is the people who are disadvantaged the most in this country due to segregation, due to our history, tend to be people who are in the minorities, Black or brown being the most prevalent ones, not to diminish anyone from any Asian ancestry as well, or Native American history. But it's the people who are not white is what it boils down to. And so the racialized capitalism in healthcare occurs when people have differential access to it and differential outcomes. And we have that issue is because we operate like a business. Hospitals, they profit on the fact that they do procedures that are elective, and that builds them money. And they have small profit margins overall, even though they do bring in a lot of money. But they depend on those. They do not depend on the fact that we need to treat everyone the same, regardless if they come in homeless and septic and they need to be treated, or whether or not they come in and they want an elective knee procedure. That's just not how our healthcare system is based. And as long as we continue to do it in that fashion, we're not going to have the same outcomes for all people.
Okay, thank you. One question has come to us: why a 50% reduction in the death gap within 30 years? Is it realistic to try and eliminate the gap, or is that completely unrealistic?
Well, that's a great question, and that's been asked. We did a back of the envelope. This was pre-pandemic. Pandemic has widened life expectancy gaps. By the way, the problem of life expectancy in this country, again, the richest country in the world with the most expensive healthcare system, you can see this disconnect between healthcare system and outcomes. How it's a fraudulent, we're in a fraudulent idea that, you build more clinics and hospitals and all in suburban and fancy areas, never in poor areas in general, and you're going to get better outcomes. Actually, nothing could be further from the truth. What we've seen in the United States before COVID was 3 out of the last 4 years, life expectancy has dropped in this country. And it's dropped because white people, particularly white people without college degrees, are beginning to experience the same life expectancies like Black people with college degrees. So just to put on, but what's happened is, and economists have called them diseases of despair, overdoses, cirrhosis of the liver, but actually a lack of progression in heart disease. So many of the problems that have plagued Black communities, as we've deindustrialized white communities in rural areas in this country, have found the same thing. Now you throw COVID on top of it, and we're going to see, we've seen already the first half of 2020, a 1-year drop in life expectancy overall, but I think it's about a 2.5 or 2.7 years for Black people. So that's the context of this. So we set this goal to reduce it before all of this. And so it was on the back of an envelope. It was possible if we could get everyone's blood pressure controlled, right? There's certain ways, cardiovascular disease, 126,000 people on the West Side with high blood pressure. There are ways we know we can reduce it. Many people are insured now under the Affordable Care Act. So we have the possibility to do it. But we also felt it was important to have a meaningful, aspirational, specific, and time-limited goal that we could all organize around. And so in some ways it's aspirational. We think, before COVID it was possible. Will we get there? Probably not now. But actually copying our work, the City of Chicago's Healthy Chicago 2025 plan is calling for the same things. And there's a way to do this. And there's a way to do it. We think that the model around West Side United is that model of this partnership model. But we've got to build now the roads and pave the pathways that get, it's not just healthcare. And there's a question in the box. It really is, we have to provide jobs. We have to do educational opportunities. We have to link the people who are youth and stuff to the opportunities and other things like that as well.
Okay, another question is, racial violence is wrapped in capitalism. How do we, begin to separate ourselves from the capitalist structure that we must all abide under without sacrificing ourselves?
Well, that's a great question. I think we must sacrifice ourselves. So I'm going to put this up. Everyone knows what this is. iPhone, we all have one, right? Capitalism is a great system for creating products, but it does a couple other things that are pretty terrible. It concentrates capital in the hands of few. That's just the mathematics of capitalism. It just does. So this idea that the rich get richer. So we're all slaves to this. We've chosen to be that. So there are countries that have done it better by regulating capitalism. So one is, we have health is not a human right in this country. That's how I started. I'm a human rights activist. That's my work. We could declare health as a human right. We've decided, we've done other things in this country. We've eliminated slavery. We didn't eliminate racism, we eliminated slavery. We've given women the right to vote. There's a set of rights that, what you have in this country is the right to bear an arm and the right to speak. These are very limited rights. I would ask you to look at Franklin Delano Roosevelt's second Bill of Rights, 1944. He died before his term, but he had a second Bill of Rights after watching the Depression. And he said, I'm going to name a couple. You should have the right to work and get paid well. You should have a right to have a home. You should have a right to health care, and et cetera, et cetera. We have a country, we think we have rights. No, we don't have rights. And so we've got to make this a human right, and we've got to regulate. We should eliminate capitalism from healthcare by adopting a universal healthcare system that's single payer. Because right now, the capital decisions around who builds what and who gets what specialists, back to the breast cancer problem, is totally based on the profits of an institution. And institutions in Black and brown neighborhoods, I say in my book, our book, are required to take a vow of poverty to serve Black and brown people in this country, or poor white people in rural areas. And so we need a single payer, government funded healthcare system that is available from birth in your whole life, wherever you go. Will that make it better? Yes. In Canada, so what we've seen in this country is a growing gap between the top 20% of the population in terms of wealth and the lowest 20% in terms of wealth, a growing life expectancy gap between rich and poor. It's Black and white for sure, but it's rich and poor in general. And in Canada, that gap has narrowed. And so we have a lower, Canada literally crossed the border, and their life expectancy has been rising while ours is falling. Is it their genes? Is it their beliefs? No, it's their public policy. So I think the point is we just have to do something, but we have to put ourselves on the line for it. You know, you see what the white supremacists are willing to do.
We're going to go a few more minutes over time. I want to acknowledge that some people may need to leave at 1, but we'll go for another 5 to 7 minutes since we began a little bit late. Another question that's come to us: what could universal health? Well, you've actually kind of addressed this issue. What could universal health care do to undo this disparity? You've sort of spoken to that, I think, unless you want to elaborate further.
No, it's, you know, it's obviously health, and healthcare is a piece of it. And it's got to be, as Kristen said, equal access to quality healthcare. It's not just access. And actually what equity means is those who need more should get more. We did a study a number of years ago on low birth weight in Toronto and Chicago in Black and white people. And in Chicago, there was a Black-white gradient. And the highest infant mortality rate was twice that of that in Toronto. And in Toronto, there was no Black-white gradient. We asked the question why, and they said with 3 reasons. We think that we're doing better in Canada, despite race and despite poverty. There's still poverty and there's still Black people in Canada, especially Toronto. They said, number one, universal health care. People have health care from the time they're young, and it touches them their whole lives. So conditions or other things that could be identified can get treated. Number 2, universal access to higher education, because we know that's the number 1 driver of life expectancy. The third thing is they say those who need more get more. That when someone falls off the tracks, let's say there's addiction or there's some other problem, homelessness, they put their arms around those women. That's the 3 reasons. So yeah, it's not just universal healthcare, but it's an approach to human beings around universality and the understanding there's always going to be a group of people who need more.
I want to echo on that, actually, what David was saying too, that he kind of just explained it. But the fact that is this going to undo this disparity just with universal healthcare? Absolutely not, because you have to get to the root causes of it. And the fact that people living in different communities have differential access to resources is the big thing when it comes to, you know, whether or not that's business in the workforce or the access to just having groceries with fresh fruits and vegetables and you're not living in a food desert. That also plays into it. So it's not just the universal healthcare access as he stated. It's the fact that you actually have to bring up these communities to have equity.
And if you think about how it breaks down, only 20% max, maybe 15% is healthcare. It's an important one in this country because we don't have universality and we don't have equity, you know, but it's the 80% are other things. And of that 80%, 60% are the conditions on which people live, work, and play, all the things Christian mentioned.
Mm-hmm. We've got 2 more questions we'll try to get to. You acknowledge ambivalence about admitting racism at one point in your career. How can we get white doctors to do so and commit to fair treatment of Black people in hospitals and healthcare agencies?
My God, that's a whole talk by itself.
I want to answer part of this as well, to be honest, David.
What do you say?
I want to be able to answer part of this.
Oh, please, you do it.
I think that it honestly comes with time for some of the older generation, not to say that David is old. I think that they're
very old.
But I do think that we have to integrate it into our training, to be quite honest, and into our daily lives. It's not just doctors, it's everyone. But if we're being specific to healthcare providers, there has been some movement towards including more social medicine and this approach in medical schools, but perhaps not enough at this point. We're getting better. We're moving the marker on the meter, but we haven't quite gotten there yet because they don't explicitly state racism, I think. Some medical schools do, Rush does, but others are a little bit less, are a little quieter on that topic. But I think it needs to actually be started earlier on in the education. If you can introduce these concepts, especially within the medical school level, people tend to use that within their practice. By the time they get to residency, they have a leg up. It should be taught within residency as well, I think, within the ACGME requirements. I think that actually should be in there. But we need to include this within it. It's a skill that needs to be practiced from the beginning. And if you do not have that skill, you do not have that confidence, and you do not have the ability to speak up. We speak up about patient safety, and this is a part of patient safety, and it should be taught.
Yeah, so Kristen answered it perfectly, but it's a process. You know, you can see I'm a little bit rare in this world, and we can't make this rare. It's got to be common. And first of all, you got 1 point in the world for pointing out the problem and 100 points for fixing it. So, you know, just saying it doesn't get it done, right? But it's, you know, that's just where we're at, you know.
Okay, our final question is, I'm an advocate for social medicine, but many are afraid that we get categorized as communist. Is there a new arena for social medicine growing in our country, which you sort of touched on?
So I think it's a tremendous closing question. So think about that. This is my thinking, and Chris and I have been talking about, we're writing this paper now on this subject. And for many years, I didn't realize that going to Cook County Hospital for me was learning how to practice social medicine. And you think about specialists, cardiologists, neurosurgeons, and how that's a specialty, right? You go learn stuff. But actually, the work that Kristen and I do and others is a specialty. We should all practice it. But there are a set of rules and guidelines for how to do this work. And it's got to be central to it's got to become central to the work. I started off by saying, what if we have it all wrong? What if everything I learned in medical school is all wrong? I believe that the ideas that we're talking about today are the leading edge of something that's been known for about 150 years. And the father of social medicine was a German doctor named Rudolf Virchow, who, you know, many diseases that we talk about now, leukemia or thromboembolism, came from his fantastic work. As a doctor, or the modern autopsy that we do comes from his work. But he was asked to investigate an outbreak of typhus in a region of Germany. And this was a region that was a very poor region that had a potato famine. So we heard about the Irish potato famine. This was 1848. There was a Silesia region that had a potato famine, and people were dying. And he came back, said, and they had typhus, infectious disease, said people were dying because of the lack of democracy. And he became known as the father of social medicine. We think that this needs to be central practice. We need to reorganize how our health systems are funded back to, but it can't just be a health system funding thing. We've got to think about how do we create these interactions and more fluid connections between community health centers, academic medicine, and people in their homes, in communities, right? In a more integrated, intersectional kind of way. That's social medicine. Okay, if you're worried about being called a communist for your beliefs, give it up. But you got it. What we need is people who are willing to speak up for their beliefs. Actually, many of these ideas, I get in front of Republicans, and you ask the following question, especially older group. Okay, who likes socialized medicine? No, it's communism. Okay, raise your hand if you're on Medicare. Hands go up. Well, do you know that Medicare is a form of socialized medicine? Oftentimes we get words matter, but sometimes words can be labels, and then you back it up and you have a discussion, because when you get down to values and human values, it's an example like this. House next door to you is on fire. And it could burn your house down. Think COVID, think a hurricane, think Texas, think about all of these things. It could burn your house down. Fire engine comes, but they realize they haven't paid their taxes. So we're not going to put out the fire. Is that acceptable? Yeah, we accept it for healthcare. So I think there's ways, use story and metaphor, and when you but get away from the labels and get more onto what common values we share. And when you think about values, we probably share more in common around values than you think as a country.
I want to thank you, Dr. Ansell and Dr. Pollock, so much for just a great presentation today, and for sharing this with those of us in Tompkins County and some beyond Tompkins County. And just very much appreciate you taking time from your schedules to be with us and to really educate us and to share with us this knowledge and this is wow, giving us a lot to think
I just want to point out, I'm a Binghamton boy.
about.
I've spent many an hour in Ithaca,
Okay.
Buttermilk Falls,
Mhm.
Moosewood Restaurant, so I'm an upstate New York born and raised, and much of
Wow.
my observations came up from growing up in Binghamton in the 50s and 60s. So not too far from home. Thank you for having us. I also want to
Absolutely.
point out, for those of you who give talks, you don't need slides.
Okay.
PowerPoint is overdone. Thank you so much.
Okay. Thank you. Thank you. And we will see